Hello, everyone. Hola a todos. Before we get started, we have some instructions since this is a webinar that we are conducting both in English and Spanish. Gracias a todos. Tenemos instrucciones para todos aquellos que quieran atender en español este día. El webinar, next slide here. So this is going to be a bilingual activity. If you would like to, depending on whether you want to listen to this in English or Spanish, you can select the interpretation button. If you are going to listen this webinar in Spanish, and upon selecting the interpretation button, click on Spanish, and then click the mute original audio option at the end of that list. This will allow for you to hear the Spanish interpreter while other voices are muted. Questions and comments may also be submitted through the chat in Spanish. Next slide. Este webinar está siendo conducido en español e inglés. Si usted quiere escuchar esta actividad en español, por favor seleccione el botón de interpretación en la parte inferior de la pantalla. Se muestra como un icono de globo. Al seleccionar el botón de interpretación, haga clic en español o Spanish y luego haga clic en la opción silenciar audio original o mute original audio al final de esta lista. Esto le permitirá escuchar al intérprete de español mientras otras voces están silenciadas. Preguntas o comentarios también pueden ser sometidas o pueden ser enviadas en el chat en español. Next slide. So good afternoon, everyone. Thank you for joining us. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health in Public Housing. Thank you so much for being with us today. I'm glad that you are able to join us. We have a great list of panelists who will be sharing their experiences and everything they do during emergencies. Some housekeeping instructions before we get started. At this moment, all participants are muted. All cameras are off, but if you would like to participate, you can also turn your camera on. If you would like to ask any questions to any of the panelists, you can use the chat feature, and you can type your question. You can also raise your hand, and if you want to reconnect to the audio on mic and participate. This webinar is being recorded, and presentations will be shared with participants by email. Next slide. We have a great agenda. First, we are going to just give you a very quick introduction about NCHPH. We are going to introduce our speakers. We are going to hear from Public Housing Primary Care Association in Louisiana. And then we are going to hear from Francis, who is at Camilla's Health Concern, then La Maestra Community Health Center. And then we are going to discuss the importance of collaborations and partnerships. At the end, we're having a Q&A session in case you have any additional questions to the panelists. Next slide. The National Center for Healthy Public Housing is funded by HRSA to provide training and technical assistance to community health centers. We serve all health centers, but we focus on those located in or immediately accessible to public housing. And the mission of the National Center for Health in Public Housing is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and a range of technical assistance. Next slide. So I am very pleased to have Vera, Francis, and Tom today. who will be sharing their experiences they are from different states. As you remember, we hosted the first webinar with Puerto Rico Primary Care Association, la Asociación de Salud Primaria de Puerto Rico, and 2 health centers in Puerto Rico who also shared their experiences and best practices during emergencies. So it's now a great pleasure to hear from other states who will also be sharing experiences and best practices. So first, we are going to hear from Dara. And Dara Stout is the practice management coordinator at the Louisiana Primary Care Association. As the practice management coordinator, Mrs. Stout is able to execute a comparative analysis of health center operations and programs, thereby informing strategic improvements and bolstering center operations and programs, thereby informing strategic improvements and bolstering management essentials. She assists health centers through finance, feasibility studies, clinic assessment, and gauging program effectiveness and overall clinic flow. She also serves as the emergency operations coordinator and is actively engaged in the nuances of CMS emergency preparedness rule requirements. Mrs. Stout has worked in the medical field for 25 years. Before joining the Louisiana Primary Care Association team, she worked at the Louisiana Department of Health Bureau of Primary Care and Rural Health as a practice management consultant and in the Office of Public Health Bureau of Performance Improvement. Mrs. Stout earned a Bachelor of Arts degree in English and Speech Communication from Louisiana State University. In 2018, Mrs. Stout earned her certification in project management. Then we are going to hear next from Francis. Francis Fran Jennings is a senior healthcare executive with 2 decades of substantial industry experience. Fran Jennings' passion for overseeing large institutions with a personal touch is contagious and has strengthened and motivated the staff, patients, and community wherever he's been. Fran Jennings' work has transformed multiple organizations, raising their profile through streamlining operations and bringing in additional resources to exponentially expand their footprint. The Chief Executive Officer at Camillus Health Center, Health Concern in Miami, Florida, for nearly 5 years, he sought and received nearly $10 million in government and philanthropic support for vital services and expansion. In his previous role as the President and Chief Executive Officer of Care Alliance Health Center in Cleveland, Ohio, he oversaw great improvements in efficiency and a dramatic expansion of services and space, while maintaining a firm commitment to quality and patient-centered care. During his tenure, Care Alliance doubled its footprint in size, budget, and scope. It became one of the few homeless service provider organizations nationally recognized as a level 3 patient-centered medical home, the highest level of recognition, integrating behavioral health service into primary care operations and launching a one-of-a-kind integrated mobile clinic were just two of his signature achievements. And last but not least, we are going to hear from Tom. Tom Boo served as Executive Director for La Maestra Community Health Centers. In this role, he oversees the organization's operations, including risk management, compliance, safety management, medical records, and patient and partners with leadership across the business to foster innovation, support growth, and drive excellence. With more than 10 years of progressive corporate healthcare experience, Tom brings a strong background of healthcare leadership, strategic insight, and diverse experiences to his role. Most recently, He was responsible for business licensure, workplace policies, HIPAA compliance, emergency preparedness, medical credentialing, and company-wide training. He remains passionate about developing others, creative thinking, and lean continuous process improvement. Next slide. Just a quick overview of health centers near public housing. In 2020, the most recent UDS data, there were 435 health centers located in or immediately accessible to public housing, and they serve 5.1 million patients. 100 of the 435 health centers receive funding from HRSA to provide services to public housing residents. And in 2020, they serve over 800,000 patients. Next slide. When we look at public housing demographics, there are three issues that are very important when we discuss emergency preparedness. The very first one is that 35% of the household report to have at least one person over the age of 65, and 38% of the households report to have at least one person who is disabled. And 37% of them report to have at least one child. And the other data that I consider important is that 55% of them have less than a high school diploma. Remember that these four populations or these four social determinants and ethnicity issues, we need to take those into consideration, because these are the populations that are highly affected during emergencies. Next slide. Just a quick reminder, we have natural and human caused disasters. Depending on where you are located, you know exactly, you have already assessed the type of disasters that are going to affect your health center operations. Next slide. And at this moment, we know that we have an outbreak, a pandemic, COVID-19. It has created the biggest issues in the communities. And recently, we have this tornado in Kentucky affecting many people. And so we need to get ready and get prepared, because some of these emergencies we don't have time to prepare for. So it's always important to have an emergency preparedness plan in place before any of these disasters or emergencies. Next slide. Next slide, please. So according to the Health Resources and Services Administration, health centers play a critical role in providing support to communities during and after a disaster. Health centers need to have dedicated staff for emergency preparedness, and it's important to collaborate with local partners such as community organizations, churches, community agencies, or others to continue medical services, and set realistic goals for coordinating emergency preparedness. Next slide. Next slide, please. As I mentioned, it is always important to have collaborations and associations in the community. It's really important to identify local partners and develop a team, set goals, serve your community, and celebrate successes. Next slide. We've been working with other organizations in the past, and currently we are working with federal organizations like CDC, FEMA, or nonprofit organizations such as the International Red Cross to gather information and best practices that we can share with health centers. And currently we are working with Puerto Rico Primary Care Association. We are very pleased with our partnership, and we are exchanging information and best practices. And this is one of the reasons why we are conducting this two webinar series, just to make sure that all health centers receive information from different states and best practices or promising practices from different states, as well as challenges. Next slide. So now I am very pleased to turn it over to Dara. Good afternoon, Dara.
Good afternoon, Jose. Hi, my name is Dara Stout, and I'm with the Louisiana Primary Care Association. Louisiana has always had active hurricane seasons, and in current history, we have had 9 hurricanes since 2017. In 2020, the most significant storm to affect us was a Category 4 storm named Hurricane Laura. And in 2021, this year, another Category 4 storm, Hurricane Ida, hit our state. Next slide. LPCA is part of the Louisiana ESF 8 coalition. Oh, I'm sorry. Next slide, please. Thank you. ESF stands for Emergency Support Functions. The Governor's Office of Homeland Security and Emergency Preparedness, which we call GOSEP, begins sending us messages as soon as a severe weather event is identified. Messaging continues until the threat or event has passed. LPCA Emergency Preparedness forwards these messages to all of our FQHCs and our staff. At the same time, LPCA reaches out to all of our FQHCs to let them know we are standing by, ready to help in any way we can. Before and after weather events, I send out our LPCA after event emergency damage survey. I send it before so they can have it available to fill in and send to us as soon as they need to and are able. But we also send it to them after the event. Next slide. Our health centers are in constant contact with regional and local government agencies while preparing for the weather event. Many of our FQHCs have sites in multiple parishes. A parish in Louisiana is the same as a county in other parts of the US. FQHCs follow evacuation orders in the different areas for their clinics in those areas. Emergency evacuation shelters open throughout the affected and surrounding areas if evacuations are ordered. The clinics contact the patients, make provisional care plans, fill medications if warranted, and reschedule appointments. Throughout the event, centers with robocall software send messages to their patients advising them of clinic status. Most of the clinics have generators and make preparations for medication refrigeration. The clinics pick up those loose items outside of the clinics, and if the area is prone to flooding, equipment inside the clinics is raised to countertops. A few years ago, LPCA led an introduction to satellite phones project and supplied phones and satellite services to 10 FQHCs for 1 year. During that time, there was never a time when the phones were necessary, and when the project was over, none of the health centers enrolled for satellite services on their own. However, after Hurricane Ida, when communication was interrupted for weeks, there are some health centers who are looking into obtaining them now. Next slide, please. Next slide. FQHCs in Louisiana are outpatient clinics, but in New Orleans, Odyssey House, Louisiana has outpatient on-site housing, which is a rehab transition program. Their clients may live in their quarters for 3 to 6 months. Each residential client completes an individual evacuation plan upon coming into care at Odyssey House. In the event of a citywide mandatory evacuation, which happens frequently in New Orleans, Odyssey House connects these clients with the city's resources and provides transportation to shelters whenever possible. When a citywide mandatory evacuation order is not issued, as with Hurricane Ida, shelters are not open and therefore not available. In the case of Ida, staff at Odyssey House remained in the residential housing with the clients because if the residential program had closed, those without evacuation plans would have been literally out on the street. Since most Odyssey House inpatient residential clients are FQHC patients, when a storm is identified as heading toward New Orleans, clinic staff start working with each client on any medication needs and issue refills where it indicated. As with other FQHCs, they also ensure that all their non-resident patients with pending scheduled appointments are contacted and assisted with any time-sensitive needs. Next slide, please. After the storm passes, LPCA sends to all FQHCs the LPCA after event emergency damage survey by email. We continue asking for the survey to be completed until all damages are reported and the clinics are all open. This information is passed on to HRSA and various humanitarian organizations to help the FQHCs with equipment, medication, and medical supply needs. LPCA collaborates with organizations in Louisiana after disasters. Those organizations are FEMA, Direct Relief, AmeriCares, Mutual Aid Disaster Relief, and the American Red Cross. Since the devastation of Hurricane Laura and Ida, some FQHCs have closed clinics due to damages. Many were closed for months due to loss of power and other utilities. There are still clinics closed from Hurricane Ida and Laura in 2020, and at least 5 are still closed due to Ida this year. Next slide, please. Okay, here is a link to the LPCA after event emergency damage survey. Theta, do you think we could click on it?
Yes, give me 1 second.
Okay.
I need to reshare my screen.
Okay.
We're done. There you go.
Okay. This is our survey that our FQHCs fill out after an emergency event, whether or not they have any damages, so that we know if they are opened or closed and if they need help. So Theta, would you please click on initial report and then click on submit? In the initial report, we request the name of the event, and next we ask for their identifying information and contact information. If we go down to operational status of the FQHC sites, here they tell us if they are open or closed or partially open. And further down, they identify which sites are affected and the reasons they are closed. HRSA likes to know which parishes they are in, so we request that information and then ask for the impact to their service delivery for HRSA programs and COVID-19 specific programs. If they have sites that are closed, we ask for the estimated date of returning to full operations. We ask if they need help from FEMA or other humanitarian organization and ask which supplies they need. If an FQHC is open without services being affected by the event, we ask if they will see patients of the clinics that are down and if they may have supplies to share or even staff. So that is it for the initial report. Beta, if you could go back to the top and click on update. Yes, you will see that the survey asks then for only the information that has changed since their initial report. These reports go into a spreadsheet where we can see it at any time, and I use that to send reports to HRSA. And we are working on a dashboard to put on our homepage website to allow others to view the reports to see who is down, and they're all very interested in knowing how the others are doing. So that is it for the emergency damage survey and my presentation. So you can close that out, Theta. So are there any questions? All right.
Thanks, Dara. That is great. I love the survey and how you collect information after and during the disasters. So that's fantastic and very useful for other PCAs, to implement in case they don't have something similar.
I have a question, Dara.
Yes.
As Dr. Leon was saying, it is so very useful for PCAs because we serve under the same function. So I was curious to know how long you've been using this kind of technology and what is the feedback on the side of your health centers.
Well, we have just started implementing this questionnaire as it is this year for all our weather events since probably August. Before that, I would send out a spreadsheet to all of our centers asking pretty much the same questions. But this way it is faster for the health centers to fill out. It doesn't seem as daunting to them as looking at a spreadsheet. And it's worked out very well. We've had some really good participation with it.
Well, kudos to you. It looks great.
Thank you.
Thank you, Marie, and thank you, Dara. There is one more question, Dara, and is what do you and HRSA do with the data you report?
Well, the data that I report, I use to, I am contacted constantly by those humanitarian organizations, and then I will, if it's something that I haven't heard from anyone about, I will contact Direct Relief or AmeriCares or whoever could help them with that information. For HRSA, I report that to our project officer. She has requested that we do that, and she uses it to keep abreast of what's happening. And then she says she reports that information to her superiors.
Thank you so much. And if there are no other questions, now we're going to hear from our second panelist, Francis. And Francis, just a quick reminder that I got that if you please slow a little bit, and pause so the interpreter has some time to translate. Thank you, Francis, and good afternoon.
Good afternoon or good morning, wherever you are. Pleasure to meet you all virtually. My name is Francis Afram Jane. I am the CEO for Camillus Health Concern. Camillus Health Concern was established in 1984. In 1988, we became FQAC, providing primary care, behavioral health, oral health, and social service to individuals and families experiencing homelessness in Miami-Dade County. CAC, as we are affectionately called, is the only freestanding comprehensive healthcare for the homeless that receives HRSA, Health Resources and Service Administration, DAOs to provide services to those experiencing homelessness. Next slide, please. We Community Health Concern currently have 3 sites. We are located in South Florida, specifically in the Miami neighborhood. We have 3 sites. They're all within 10 minutes proximity. In 2021, we became PCMH accredited. Same 2021, we were awarded quality badges, which is quality award, because we met several indicators established by HRSA. COVID-19 Health Center Quality Leaders Award, Access Enhancer, and then Health Disparities Reducer. And it's very important to think about a homeless service provider competing with some of the big players in the community health center world, which currently we have about 1,400 community health centers. So we strive for quality and we strive for financial viability. We also received American Heart Association for quality in blood pressure work. Our demographics, as I said, are those experiencing homelessness or newly immigrant in town. 40 individuals are Asians, over 2,000 individuals are African American or Black. And then American Indians / Alaska Natives, we have about 100 individuals. White comprise the most of us, which is over 3,000 individuals. And it's the combination of the white is that some of the Hispanic, because this is a self-reporting metric, some of Hispanics identify themselves as white. So it really inflates the white demographic number. And then more than one race identified almost about 200. Number of patients served by the 2020 UDS data, we saw about 6,000 individuals. That translated to almost 35,000 visits. And then 62% of those that we saw experiencing homelessness. Next slide, please. We have our continuity of operations plan that we call it COOP, and we attach the plan as well for the council that could share with any attendee that would like a copy of it. We broke it down into fire response, flood response, but today we're zeroing on the hurricane response, and then the infection control and violence will be another time, but right now it's mostly about the hurricane response, because in Florida, specifically Miami, hurricanes is our #1 emergencies that we deal with. Next slide, please. So as earlier, Dr. Leon expressed eloquently, everything is about partnership and collaborations. No entity can be ready for emergency preparedness, not even FEMA, not even CDC. So effective collaboration is extremely important. So we have national partners when we are doing emergency preparedness that we learn from them, they learn from us, and we collaborate appropriately. The National Association of Community Health Centers is one of our national partners. National Healthcare for the Homeless Council is one of our national partners. Federal Emergency Management Agency, which is FEMA, is our national partner. Direct Relief, as Dara said earlier, Americas, and now we're going to add NCPH to it, the council to it for public housing. Next slide, please. As we said earlier, you can't do it all alone. So we also have state and local partners. One of them is Florida Department of Health, the Miami-Dade. We have Miami-Dade Homeless Trust, which is the go-to entity in South Florida, addressing the needs and issues of those experiencing homelessness. We have Public Trust, which is our safety net hospital. We have Health Choice Network, which is made up of 49 community health centers that they provide IT support, and then during emergency preparedness, redundancy, so that wherever you are, you can access patients' medical records. We have homeless shelter providers. We have Camilla's House, which is our sister organization where people stay. And then when the emergencies are coming or hurricanes are coming, we dispatch outreach teams to bring them to stay at the house so we could feed them and then make sure that they're not on the street with this vagrant weather. We have Salvation Army, which is also a homeless service provider. We have Chapman. We have Miami Rescue Mission. And the last one that we work with very closely is Lotus House. It's one of the few shelter providers that house women and children in South Florida. Next slide, please. Going back, direct relief emergency medical pack. This is important because direct relief gives us medication, donated medication, and it helps our operations a lot. But more importantly, when emergencies like hurricane is coming, they always deploy emergency medical pack that we're able to distribute to our clients. And this is a picture of them. Kits that address infection control, trauma care, diagnostics, personal protection. So this is a picture about what we received from direct relief about a medical pack for emergencies. Next slide. Recently, one of the partners that we work with is called Miami-Dade Healthcare Preparedness Coalition. They issue a request for proposal. We applied for and competitively competed with other hospitals, health systems, and other entities. And we were lucky to be awarded almost about $60,000. And our application was centered on what we call mobile telehealth care. So in emergencies, this backpack you're seeing, anyone who has been trained on it could take it to where the disaster has happened and able to assess people's blood pressures, whatever they need at that moment in time. The nurses, the doctors, the APRNs are able to carry this bag. It's pretty light. And this bag, when they do that, are linked to the client's systems so that they could know what happened during the emergencies. We're working through some of the kinks, but that's the essence or the importance of this grab and go, as we call it. Next slide, please. Next slide, please. So what are some of the challenges and what are some of the best practices that we've learned all these years? And yes, we've learned a lot in Florida with the hurricanes and the emergency preparedness. Our best practices will be, you have to know the population that you serve. With our partners, when we know that hurricane is coming, all the outreach teams from regardless of the shelters, Miami-Dade, the Homeless Trust, Camilla's House, Camilla's Health, we know where people experiencing homelessness congregate. So we dispatch these outreach teams to bring them to shelters or to bring them to safety places. So you have to know your population. You can't wait till when emergencies are coming, when you're rushing to deal with the population that you serve. And we always practice tabletop exercises, whether it be active shooter, whether it be hurricane coming, whether it be infection control. So it's very important that constantly be on the forefront of your patients and also your co-workers specifically. What are some of the challenges we've experienced over the years? Is the ease of communication. This specifically pertains to our clients, because they're transient in nature and a lot of them don't have phones that you could reach them. So it makes it very harder to know where they are to actually provide care to them or to even evacuate them into safe places. Limited on-call clinical team. During emergencies, people are also preparing their homes. People are also preparing their neighbors' homes. So the same providers that will be able to dispatch to provide services to those affected by the hurricanes are sometimes very challenging because they serve in different roles, family roles, business roles, and then also caring for the community that relocated. And also during the emergencies, accessibility to clinic is very difficult. Tree leaves, falling trees, and things like that. So those are some of the challenges during emergencies. And next slide, please. At this point, that concludes my presentation. And thank you very much for the opportunity to speak in front of you. I will yield it back to Dr. Leon.
Thank you,
If
Francis.
anybody has a question. Yes, thank you, Dr. Leon.
Thank you for that great presentation and for sharing your emergency preparedness plan and your challenges and best practices. And while we wait for a question, Francis, I have a question for you. And you serve a very vulnerable population, one of the special populations, listed by HRSA. People experiencing homelessness, they are hard to reach. And I wonder if you coordinate any activity with your public housing agency during emergencies, Francis?
Yes, we do. So part of the Healthcare Preparedness Coalition are made up not just hospitals, health systems, or healthcare providers, but also housing entities. So during preparation and training, we know where those public housings are allocated. Where we have a lot of public housings around us. So we do training and we reach out to them, give them some flyers. If there's anything happens, this is the point person to reach out to, and then we will deploy what they need. We do not receive public housing funding yet. However, we use our outreach teams to go to public housing to provide services to the residents of the public housing.
Thank you, Francis. And Maria from Puerto Rico PCA would like to ask you a question verbally. Maria?
Sure, Maria.
Hey, Tom, I love what you shared, and it very much models what several of our health centers, as well as the PCA, does during an emergency. I wanted to know what kind of technical assistance does your PCA provide to you, or in the case that there is none, what would be useful for the health center that the PCA is available to provide?
Well, Maria, thank you very much for the question. We are fortunate. Our PCA, Florida Association of Community Health Centers, is very active in emergency preparedness. I mean, frankly, they have a full-time dedicated person who handles this. So that person will be in constant touch with the state emergency preparedness team. We'll be in constant touch with NACHC and all that. So they'll be deploying information when the hurricane is coming, the wind speed and all that. And then make sure that all of us, whatever we need, particularly in terms of medication and all that, are stored appropriately. And if not, link us to the hospitals or places that have the bigger storage facilities that we could store. So they constantly help us with that. Could they do more than what we need from them? Absolutely, yes. Because sometimes being in this community, being in Florida since 1999, when I finished grad school and spent some time and I moved to Cleveland, some years you could get about back to back, like Dora said, in Louisiana, and resources are so limited. So in those years, we need more of guidance, we need more of support, and those are limited from their side. So yes.
Thank you. And that's really interesting in the point of view that PCAs always want to provide, and we know that the burden in community health centers is often, we forcibly had to take emergency preparedness into a more day-to-day function, precisely because the workload in health centers is so high. And so I ask because it's always good for a PCA to know how they can be more efficient and more effective in the technical assistance provided to health centers to always, always with the perspective to ease the burden. So thank you so much.
And thank you very much, though, for your feedback and your comments about that, Maria. Okay, now back to Dr. Leon, please. I think you muted.
Dr. Leon, I believe you're muted.
Yeah, I think he's muted.
Sorry about that. Francis, we have another question, but we would like to save that question. So if we can get back to you at the end. At this moment, I would like to introduce Tom Wu from La Maestra Community Health Centers, who will be presenting on what La Maestra Community Health Centers does during emergencies and everything that is related to their emergency preparedness planning. So, hello, Tom.
Hello, thank you very much for having me today. I appreciate it. Yes, my name is Tom Wu. I serve as Executive Director for La Maestra Community Health Centers here in San Diego, California. In my role, I oversee our operations. It includes risk management, compliance, patient care, and safety. I manage emergency preparedness activities for the organization. It includes training and education to our health center staff who come from the cultures that we serve here in San Diego. Next slide, please. So a little bit about our operations gives a bit more insight on how we plan for emergency preparedness. La Maestra operates health centers in diverse communities with some of the biggest medical and economic needs in San Diego. 90% of the families we serve are low-income immigrants and refugees, and over 80% prefer to be served in a language other than English. The majority of our patients are from Mexico and Central and South America. There's also a large number of Africans, Middle Easterns, and Southeast Asians. Next slide, please. We provide medical services, dental, behavioral health, and in addition to that, we also provide a wide range of support services that go beyond primary health care, like health education and outreach, job training, transportation, housing assistance, and food. And because we play such a large role in the safety of the communities we serve, we become the community's support system during a disaster when they're looking for information. We expect that patients will come to us for triage and information, and in some cases, shelter. Our patient demographic includes those with chronic disease and patients with mental, behavioral illnesses, anxiety, depression. So we try to integrate our emergency preparedness plan with agencies and local and state levels as well. Next slide, please. Our emergency preparedness is divided into 4 parts: planning, implementation, testing and exercises, and program improvement. With planning, we consider our community and our health center size. We have 3 floors with underground parking, 2 floors of underground parking. We have satellite clinic locations located throughout San Diego County in diverse communities with over 30 languages spoken. Again, patients with chronic disease. Our hazard vulnerability analysis helps us determine where we are most susceptible to emergencies. In implementation, we involve our staff in planning and carrying out activities. We rely on them. We have a dedicated risk manager as an officer for the organization who can designate time each day to enforcing safety and emergency policies. Regular safety and emergency exercises help us to test the management and decision-making of our programs. With wildfires being so common here in California, evacuation exercises help remind us of the procedures and the systems and how to use equipment. And then improving our program by reevaluating with risk assessments at the clinic sites because it's easy to have a false sense of confidence when disasters aren't very common, and keeping close partnerships with the community to leverage our resources. Next slide, please. Cybersecurity has become a recent priority with us in our planning. With healthcare in general, we are seeing an increase in breaches and ransomware because of all of the protected health information that we have. And because we rely on our electronic health records, there are high impact consequences if we lose access to patient information. We have recently revised our policies on how we collaborate with outside agencies because we don't know where companies are housing our data. Our IT department keeps layers of security protection, firewalls, which protect our network from the outside, proxy internet server, which protects our network from the inside. Our security software stays updated on all of our servers, and any staff who work remotely are required to use what we call VMware to log in, and that keeps viruses from transferring from personal computers to the company server. Our IT department backs up data in the event that it's stolen or there is a disruption in service, and this falls under our IT contingency plan, so we can access a backup copy of things like patient billings, lab tests, patient information. So if there is a failure, we can rely on backup data. Next slide, please. In the event of system or network outages, we have contracted with ChartGuard, which is a business continuity solution for continuing patient care. ChartGuard is a third-party software that we use, which creates PDF copies of our patients' electronic charts for upcoming appointments, along with a copy of the appointment book and the patient's last 3 visits. And it stores them at each of our health center locations. So during a disruption, these PDFs can be printed and viewed on laptops to update appointment schedules and patient charts, and it updates information every night. We can customize the information we want to see in the charts. It includes demographics, allergies, medications, lab results. And during an interruption, our providers have the information they need to continue care. For us, this has become a big component of our continuity requirements under HIPAA security rules by providing access to clinical information during a system or network outage. Next slide, please. In the case of a disruption in service, our organization is registered as an essential user, meaning the health center is on a priority list to have services restored during a blackout. As health centers, we provide vital services, and especially during the summer months in California, where we are prone to heat waves and fires, we have to know that our services will be restored during a disruption. So I would suggest, if you can, to be listed as an essential user with your public utilities commission or company. Next slide, please. We always rely on community resources when we plan for emergencies and public health information. This includes working with the city and county of San Diego and regional planning. Even locally, we have created MOU agreements with local supermarkets and stores to provide water during an emergency, as well as agreements with gas stations to provide fuel, diesel fuel, for example, specifically for the provision of our backup generators. We work closely with the police department. For us, it's the San Diego Mid-City Division. Local fire department, our public utilities is very important. The San Diego County Office of Emergency Services, the San Diego Food Bank, the County of San Diego Health and Human Services Agency, and partnerships with local school-based sites. Next slide, please. At the community level, we know that diverse communities that are limited in English can be difficult to reach. We provide a number of translated materials with links to websites that offer translated brochures. We combine communication with local organizations to send out health information because it builds trust and visibility among the community. We use interpreters and liaisons for face-to-face encounters. And there are always efforts to increase our bilingual staff, our liaisons and volunteers. We dedicate resources to develop cultural and linguistic educational materials, and we conduct direct outreach to our communities, to patients and local residents. Our cultural liaisons understand our community and are able to integrate the community into our emergency preparedness activities. Next slide, please. Our call center here at La Maestra is typically used for administrative purposes like scheduling appointments. But during a public health emergency, we can coordinate our call center specifically for emergencies, for outbound calls and incoming calls. The call center telephone line can be established for telephone triage, where people receive up-to-date emergency instructions and guidance in different languages. Having a call center, we have found, improves the perception of trust among our patients because we can provide information that's on time, that's up to date and consistent and accessible. Even during fires, we learned that even the call center had to be moved to another location, and it is a massive undertaking to trying to reach patients. We utilize a service called Well Health, which gives us the ability to text all of our patients at once with broadcast messages. And how it looks is, it might say, hello, patient name, this is Tom with La Maestra. Due to the rapidly spreading fires, your appointment has been moved to our National City site at the following address. And then the patient can confirm yes or no that they received the information. The texts have pre-written responses for different scenarios and questions, and it is bidirectional, which means we can communicate back and forth, and it's been great at keeping patients informed. Next slide, please. One of our goals has been to be able to respond with medications during public disaster. But the challenge has always been figuring out where to store these medications and how to keep them from being exposed to high temperatures. In working with the San Diego County of Emergency Services, La Maestra is now listed as a point of distribution, a POD. And during a disaster, we have stockpiles of medications or vaccines delivered to us, up to 1,000 doses per hour within 48 hours to help protect San Diego County residents. So instead of storing medications, there's really nothing to do on our part. We just have the medications sort of in our back pocket. Currently, the County of San Diego has stockpiles of doxycycline and ciprofloxacin. So in times where this becomes necessary, the CDC ships medication to the San Diego County, and then the county distributes the medications to us as a pod, POD. And this is done through the National Strategic National Stockpile Program. Next slide, please. Patient grievances, as part of our risk management program, we review these dashboards, and it helps us to look at benchmarks and compare them to previous years. This highlights our grievances, incidents, and near misses. And this is important to us because we can see how many complaints and incidents are taking place throughout the health centers. Here, going left to right, you can see there had been a year-on-year decline in incidents until 2020, where we start to move back up through 2021 on the right. Of course, COVID is shaping a lot of the patient complaints because from the patient's perspective, their experience has changed almost overnight, where a patient could normally drop in about an issue. Now we have to deal with masks and PPE and infection control and screening patients before they can enter. So I think COVID fatigue is a real thing. Many people are exhausted, and we are receiving a lot more incidents lately about patients being upset at the screening process and the questionnaire. So these benchmarks are reported to our board of directors for decision-making with safety and emergency preparedness. Next slide, please. As a result, we acquired active and shooter insurance as a type of gap coverage to supplement our general liability insurance. Because we are open to the public, we are more vulnerable to active shooter events, especially in healthcare. The environment can be volatile as staff and employees are working to treat people who are sick while dealing with hostile patients, friends, and family members. There has been a steady increase in active shooter incidents across the US. So considering these factors and due to the times we live in now, we feel we need to proceed with insurance that would protect us from mass shootings if it were to happen to us. Active shooter insurance covers expenses related to business interruption, legal liability, funeral and burial, medical or dental care, rehabilitation expenses, and public relations counsel. Next slide, please. Thank you, Fide. So these are I see I'm running out of time, our risk management activities that tie in with emergency preparedness and some of the top risks and exposures that we're facing now and heading into next year. Because our health center is very diverse, we find it important to integrate the community into our preparedness activities, and we can identify what works and what doesn't. So we continue to evaluate our existing plans to make sure that it's always appropriate and still makes sense and is comprehensive so that we can be prepared as possible and responsive as possible in order to keep the safety and community a top priority. Thank you very much. That's it for me. I appreciate it. Stay safe, everyone.
Thank you, Tom. Great presentation. I know that we are at the top of the hour, but I would like the audience to stay with us just for a moment. We have heard three great panelists, and if you have any questions for them, for any of them, please feel free to ask any questions. In the meantime, I would like to ask you as well to complete the post survey when the webinar ends. And I would also like to announce that in February, March, we're having an learning collaborative on emergency preparedness. We have had these two webinar series. We are very pleased with our collaborations with Louisiana Primary Care Association and Puerto Rico Primary Care Association, as well as the health centers. Thank you, Francis. Thank you, Tom, for your collaboration, your support. It's always nice to hear from you and all the great things that you are doing to serve your communities. And so, Fide, do we have any questions in the queue? Or anyone who would like to ask a question?
Yes, we do have one question from Maria Cecilia.
Okay.
Says, how do you survey and monitor patient satisfaction? What's the method for survey taking?
For us here at La Maestra, I can answer that. We have a couple of ways of monitoring patient satisfaction. We do physical surveys at all of our sites, and that includes paper surveys where we collect information directly from the patients. That's a requirement from all of our health plans and the state and HRSA as well. And those are collected and then tabulated and submitted. We also use the Well app system that I spoke about briefly by sending text messages. The text messages now have been utilized more with COVID and with social distancing, and we send the survey electronically. So the Well app has been a huge advantage now in emergency preparedness, but also in collecting patient feedback, appointment reminders. So that has been the main way that we have been compliant in receiving and sending out information regarding to patient surveys.
Thank you, Tom. Francis, I would like to get back to you, and this question is for Tom and Francis. But this is the question, Francis, that I believe is a great question. The question is, Do you coordinate your emergency preparedness planning and implementation activities directly with other health centers in your area?
The answer is yes, because all the health centers in our area also are part of this Miami-Dade Healthcare Preparedness Coalition. So they're at the table with us. So there's a coordination among us, yes.
What is your answer to that question, Tom? Do you coordinate activity with other health centers directly?
Absolutely, yes. We have a coalition. It's called the Health Center Quality Partners, and it's a coalition of all of the health centers in Southern California and San Diego. It consists of 13 health centers, and that's where we collaborate and share our resources. We also participate with our California Primary Care Association, and they've been a huge partner with us during COVID. They serve, 1,360 not-for-profit community health centers, and they provide assistance with training and with advocacy and with guidance. And, we've just learned that the guidance that we have and the tools that we receive are a great starting point. It's just learning how that is applied to our facility. And it just boils down to putting it into practice, and how are we able to do that appropriately and effectively, and what does it look like for our health center or your health center. So we will think about the guidance that we receive from our partners, and but it's just a matter of, this is the guidance, how can we put it into practice?
Thank you, Tom. There is one more question, well, two more questions, this question is for you, Tom. Yeah, it was interesting to learn about active shooter coverage. Do you have any written protocols or policy procedures on how to respond to an active shooter situation?
Yes, we do. It is a requirement by all of the health plans, by everybody now. We have active shooter training that is mandatory now. And that is implemented to all of our staff. It's a new recent phenomenon, this active shooter, and we took it into account with our risk management processes. And that's why I kind of showed our benchmarks and kind of the things that we look at. We can make it systematic. We can look at the data. We can see we've had this many complaints last year. We've had this many incidents, this year. And we do have the policies and procedures. All staff are required to read it and sign it, acknowledging that they understand it. We have trainings that take place annually, and that's an internet, web-based training. And then we also conduct drills at least annually for the active shooter responses. So that has been a really big part of our emergency preparedness these days, active shooter, as well as the cybersecurity. Those are two recent phenomenons. And it's really based on the HVA, the hazard vulnerability analysis that we conduct. It's, like I said, it's a very systematic way of seeing what we are most susceptible to. And it emphasizes the training and exercises and policies that we need to develop, based on those risk vulnerabilities.
Thank you, Tom. And last question, and this question is for three panelists, Dara, then Francis, and then Tom. And this one is coming from Maria Cecilia from Puerto Rico PCA. If you can share your challenges and best practices when planning, training, and exercise. Dara?
Yes. Well, it's funny you should mention all of this, because I am working on a tabletop exercise to share with our community health centers on an active shooter situation. And what I normally do is I usually go to an expert and get them to lead a tabletop exercise. We have in Louisiana, part of our Bureau of Primary Care and Rural Health, an emergency preparedness section. And they work with us to present hurricane tabletops, flooding tabletops, I'm looking at active shooter right now that I'm hoping that I myself will be able to develop. And we usually send it out. I put it in our newsletter and send out invitations as well, promotions throughout, say, a 3-week or a month prior to the date. And with the registration information, and they register, we get, if it is a tabletop exercise, one that they can use for their CMS requirement, we get a good turnout. I'm talking 60 people, will show up. So that's usually what we do. And also, as I said, I am myself trying to generate a class that I can give to our community health centers on active shooting. And I hope, Tom, may I contact you about what you guys usually do?
Absolutely. Feel free. My contact information is there. Reach out to me anytime. That applies to everyone here.
Great. Thank you.
Thank you, Tom. And Francis, from the health center perspective,
Yes.
what are your challenges and best practices when planning training and exercise?
I would say the best practices that we have over here is that we have established every other month, we have a general staff meeting that gives us captive audience. So every other month, we break down what do we want, what will we share with staff, and we invite experts like Dora said. Last year, we had a police department that came to teach us about the active shooting. So the experts will come and we do some exercises and they ask questions, which is really interactive. Also, we will invite experts to to teach us about cultural sensitivity, to teach us about how do you recognize unbiased consciousness, so all this. But what our staff like is that one of our board members is a psychiatrist, and it will bring her partner who teaches about COVID-19 fatigue among our co-workers, how to distress. And it's really popular among us. So they come twice a year. We just had one the last staff meeting, and every year we come up with an agenda. Okay, this year is going to be infection control and active shooting. The next meeting will be this. So we plan ahead and we have everybody. Because of the COVID, we don't come together like we used to, but everybody have access that we use the Zoom apparatus to display that information. And that's one of our best practices, working with the community to bring the experts to help us understand. The challenges is sincerely not us being together, because when we were together before the pandemic, it was more interactive. We laugh among ourselves, we rehearse, we practice, and now it's everybody in front of the computer and then through the Zoom. So it makes it a bit challenging to feel that camaraderie among ourselves. That's what I would say.
Thank you, Francis. And Tom, challenges and best practices when planning
I agree.
Training and exercise?
Absolutely. I agree with all of the best practices mentioned. Meetings and trainings. We participate in the trainings, not just locally, but statewide. Here in California, we participated in one called X24, which is an open invitation exercise. It combines using social media and web tools to share information, real-time information, to help victims of a natural disaster. As far as challenges, it's always been continuing operations. So some people call it a COOP, Continuity of Operations Plan. That's the term that is sort of favored by the public and governmental entities. But continuing operations is big because emergencies, it's such a vague term, right? It could be active shooter, it could be a fire, it could be a power outage. It could be so many things, but ultimately it comes down to continuing operations, continuing to see patients because we provide such vital services. So what we are doing now and what's been a challenge is having what's called a co-location, and that's where we can house our computer services servers at another location, so that when power goes down, we can still continue to see patients. So instead of housing our servers at the main site, where it lives in a room or a section of our health center, there's the option to co-locate really important equipment. We can rent out space in a location or a data center, or we can, buy space in another city, another state. But the idea is to have a separate location where your computers can continue to run in the event of a disruption. I think another great practice is to have yourself covered as far as insurances. So I oversee our risk management as well, and we're always looking at our insurance portfolio. I mentioned, active shooter, cyber insurance, but also business interruption insurance is big, and that covers a lot of the things that you don't plan for that take place, and we hope we never have to use it. But we're always reviewing our coverages and our gaps in insurance, and we work closely with our insurance brokers, to fill that gap.
Excellent, thank you, Tom. Unfortunately, we are out of time, but thanks. I would like to thank the audience for bearing with us and for all the questions that we got, as well as I would like to thank again Dara, Francis, and This has been a wonderful presentation. You can visit our website and find references and resources. And it is my understanding that the presentation will be on our website soon, and the slides and the link to the recording will also be sent to participants. And on behalf of the National Center for Health and Public Housing, I would like to say happy holidays to everyone, and thank you so much for being with us.